Good morning. I'm Erica Bisson. I'm a professor of neurosurgery at the University of Utah, and it's an absolute pleasure to be with you for this Future Spine Leaders course, talking about how we interpret the literature. I'm going to go ahead and start my presentation, and what I want to give to all of you is that I'm going to take this from kind of two different tactics. One, what you need to do, and then another one as a bit of an editorial perspective on how to review the literature. Here are my disclosures. So as I mentioned, first I just want to talk a little bit about context and then go through very methodically a stepwise evaluation of how you look at the literature and the science behind it, and then spend a few minutes at the end really talking about what it means to you for career development and future directions. I think when we think about context, the reality is we need to know why we want to evaluate the literature or interpret the literature, what we want out of any given article that we're looking at. And the second thing is to start that stepwise evaluation. It's important for us to know that there's many different kinds of scientific papers. You know, all of you have read through papers, you've done presentations, you've written articles of your own over the course of the last several years. And really, when you think about articles, they kind of go into two big buckets. There are primary research articles and then review articles. We're going to kind of go through each of the different types of studies and how you think about them and how you might be able to incorporate them into your future practice. When you think about primary research studies, as I mentioned, there are two kinds, really observational and experimental. I think this is important when you're looking at the literature that you define some of the context of the article you're looking at, because it helps you understand and really gravitate towards what you want to get out of the article and how you can use it to aid in your practice. Obviously, the gold standard has always been randomized controlled trials. I will comment that that is, while it's still the gold standard and we consider that class 1 evidence, we are leaning more towards large prospective collected databases or registries to help us understand real world practice more nowadays. Right, I said I'd give you guys a kind of a stepwise, how do I think about scientific reviews and scientific articles. And you start where you start at the beginning. And the beginning of an article always shows you the abstract. So I would say anytime I'm thinking of looking up information, whether it's I have an interesting patient that I want to look at the literature, you know, what's the latest and greatest on a new technique. It's, you know, scrolling through a bunch of articles, and first it's always reading the abstract. And the question is, first looking at the abstract, is this relevant to the question that I am asking? If yes, then we go to the next step. But if the answer is no, I have a little picture of my trash basket, and that's where everything goes if I don't think it's relevant to my current question. And again, I'm really focusing on why you're looking at the topic. Are you looking at it because you're looking to change your practice? You want patient education, you're looking to learn a new technique, or you're reading it because you're an editor or reviewer for an article. And I think all of those things play a role in how you decipher, the information. The second thing you need to do is, once you've identified, you look through the abstract, you decide, yes, it's something you want to do, you need to identify the study type, because it's really important once you identify the study type that you understand the criteria. Today, there's very strict criteria for different studies and how they're published in the literature. It used to just be that there was the very specific guidelines we use for randomized controlled trials, but that's not true anymore. We have specific guidelines for observational studies. Those are all of our prospective, retrospective cohort studies. Those are the stroke guidelines. As I mentioned, the RCTs we've had for a long time, the consort guidelines. And then really, anytime you're looking at a meta-analysis or systematic review, it should really follow the PRISMA guidelines. Again, it's not that you need to know these criteria going in, it's that you need to apply them to the study to really understand, Is this a valid study? Did they do it right? Should I take the results in the context of how they presented their data and how they adhere to these guidelines? I'm going to just show you them because anytime you're evaluating a piece of literature, you should make sure that they're conforming to these guidelines. And there are some specific things that each article needs to include. The consort, which is the randomized control trial, if you've ever written up a randomized control trial, you will know that every scientific journal requires you to follow these guidelines and actually submit the guidelines with your article. And so you have to actually identify where you hit each of the criteria. And this isn't for you guys to read, just to understand that within each part of the article, you need to identify different things that lead to identify the things that lead to the validity of the study. This I did want to spend a second on, which is the flow diagram for randomized control trials. This absolutely has to be a figure in any randomized control trial. And this also helps you as somebody who's reading the literature, understand exactly what happened to the patient population, how they were assessed for eligibility, how many patients, and then who they excluded, who got randomized and what they got randomized to. And then within the randomization protocol, how many were followed up? Were there any that crossed over? How was the analysis done? This is one of the first things that I look at anytime I'm reviewing a randomized control trial. I flip right to this diagram because that's going to give me a really good idea about crossover, which is incredibly important in randomized control trials, and follow-up. Because the results, while they're the results, they need to be taken with a grain of salt, depending on those two things. It's also important to know when you do report a randomized control trial, they always report the intention to treat analysis first. They may report the as treated analysis as well, but the intention to treat is all based on this very specific diagram. Again, nothing for you to read here, but understand that the stroke guidelines are very similar to the consort, but for observational studies. As I mentioned, these are your prospective, retrospective, cohort studies, your case control studies, any observational studies, even if the data is prospectively collected. And again, this gives you guidelines on what things need to be included. Most of you are writing up these exact types of articles. You should take a look at this as you're writing your article to make sure you've had these very specific definitions. You can see some of the key points that you need to make in the results as well as in the discussion. And I'll make sure to share these slides with all of you. The last but not least, which is actually feels like more in depth, is the PRISMA checklist. And this is for systematic reviews or meta-analyses. It is surprising to me how many systematic reviews I read as being on the editorial board of the Journal of Neurosurgery that don't conform to these guidelines. And it's really important looking through these that they do conform, because once you miss a few key elements, particularly related to bias of the articles included, it can really change the conclusions that one can draw from the article. There is a flow diagram with the PRISMA, very much like the consort for randomized control trials. And again, this is one of the first things that I look at when I have a systematic review, is exactly how did they get the articles, which articles did they include, what was the patient population, and how did they do the analysis and inclusions. Okay, enough about guidelines. That was a lot on slides, but I think it's important as you guys kind of go through and start evaluating the literature that you take a stepwise approach to how to incorporate the evidence that you're reading into your daily practice. And part of that is being really critical about what you're reading. After you've figured out what kind of study it is, you've decided from the abstract that you're keeping it, you've gone through the checklist in your mind, the next thing you need to look at, and this is really the pieces of the article, is the introduction. So there's a lot of background in an introduction. I frankly skip to the last sentence because that's the important point. I say understand the impetus, and the first fluffy paragraphs are about what we know and what we don't know. But really the bottom line is extracting what is the hypothesis of the study? What are they looking at? And that's usually the last sentence of that introduction. And it's super important that they're very defined in the goals and objectives of the study and the hypothesis. I will say, having reviewed a lot, that the hypothesis is not always clearly stated, but the goals and objectives are, or else it is not an appropriate article to be published in a good scientific journal. The next thing to look at is the methods, and I have highlighted in red here, spend time here. I think I spend more time in the methodology of any article than any place else. And that's because if I'm reading, whether I'm reading for my own knowledge base or to guide patient care or as a reviewer of the article, I don't know if I should trust what the results and conclusions say unless I understand the methodology, unless I understand who was included, who was excluded. Is there a situation where there's going to be a lot of selection bias, which is the cohort is, maybe it's a single surgeon experience and they excluded, a large portion of the patient population, or they only included people who had 12-month follow-up. Well, what if the patients who didn't have 12-month follow-up weren't doing well and they went to another surgeon? So you have to think about those types of things. I look at exactly what data they included. It's important when I'm going into the methodology that I think about not just the hypothesis, but what are the outcomes variables that they're going to be looking at? What are the independent and dependent variables? What are potential confounders? How are they collecting the variables? How are they measuring the variables? All of those things are important, again, in helping you decide. You're not just reading an article and taking it at face value. You really need to critically analyze the literature if you want to incorporate it into your practice. And then I look at the statistical analysis. I happen to have an MPH and did a lot of work on epidemiology and statistics. So for me, this is the way I can geek out into the understanding of the numbers and understanding that they did the appropriate statistics for the data they have. But even if you don't know a lot about statistics, it's important to know that they're doing the appropriate analysis for the data that they have. I think most people spend the vast majority of time here in the results. And the results is just the facts, right? This is no interpretation. This is just exactly what they found. And usually it's a description of the findings of the study, particularly as they pertain to the primary hypothesis. And usually folks will report out the primary outcomes first and then the secondary outcomes. That's not always the case. Particularly if the primary outcomes didn't kind of come to fruition and they want to focus more on the secondary outcomes, but it should all be in there. I find that it's really helpful before I start reading the results that I flip to the figures and tables. I find those which show you the results in a graphic fashion almost as helpful, if not more helpful, than actually reading the results. And then I go back and read the results in descriptive form. But the figures and the tables are really going to give you kind of the gist of exactly what they found. Most of you know table 1 is going to give you a lot of information on demographics, and if they're comparing two groups, that's going to be a comparison between the two groups on kind of baseline level information, age and sex, and maybe BMI, smoking status, things like that. And then as you go further on, your tables 2, 3, and 4, or your figures, are going to be the actual outcomes measures. Again, I talk about the statistical analysis. They will report it in the results, but you have to have known what it should have been from the methodology, and that they actually report what they said they were going to report in their methodology. And as I mentioned, it's really just the facts, but this is it. This is where you get kind of the meat of what they want to show you. And then you can go on to make your interpretation, and the authors themselves will make their own. And then the discussion, which is the interpretation of the results. And really, For me, I read two things in the discussion before I go back and read the whole discussion. I read the first paragraph, which should really summarize and interpret the results of their study. And then I go to the limitations. I actually don't go to the conclusions next. I go to the limitations, because there are limitations to every study that's done, whether it's a systematic review meta-analysis, a randomized controlled trial, or some kind of observational study. And to know that the authors recognize the limitations as you already are checking those off in your head when you're going through is super important, that there's recognition of those and how those may have impacted their results. I then go through and read the rest of the discussion, which is always, you know, quoting many other, all the supporting literature, kind of for and against, things that agree or disagree with the findings that they came to in their particular study. Also, the conclusion I find interesting. It's usually only 1 to 3 sentences in almost every paper, and really they just want to highlight the exact findings. It's not a lot of interpretation. It's really kind of a overstating of the results, and it's important that the conclusions that they draw are both relevant and accurate. And I find that as on the editorial board, where again, I review many articles in any given week, that is one of the weakest points of some of the papers that I'm reviewing, is that the conclusions aren't really supported by the results presented in the article. So I think that's something as a new practitioner, you need to be cognizant of, that not every article, what you read in the conclusions, is proven in the results. And so I think sometimes people only read the abstract or read the introduction and conclusions. And if you miss all the bulk of the data in between, it's really easy to take something at face value. And I would caution against that. So again, quick look, read the title on the abstract. Again, stick it in the circular file if it's not relevant. And if it is, keep it. Again, most important sentence in the introduction is usually the last, which tells you either the goal, objective, hypothesis of the study, and then that first paragraph of the discussion, which is the interpretation. And then again, look at the figures and tables. Look at the figures and tables. This is where your results are. You can read it, but it's so much easier to actually look at the data in table and figure format. I wanted to, that's kind of how you look through a scientific paper. And I take that, that kind of tactic with when I'm training my residents how to evaluate the literature. But then I wanted to take a few minutes to really talk about why and the logistics of it. So first, kind of logistics of it. When I was first starting off as an attending, I remember I thought, oh my gosh, I have to read every article in every spine journal every month to stay up on the literature. And frankly, that is just not feasible. So I think, you know, you should start thinking about what is going to be my time commitment to this, and then how am I going to navigate it? I think reviewing the table of contents of several of the major spine journals monthly is very important. I think things pop out at you if you're not getting the physical journal delivered to your office or to your home. I think just scrolling through the table of contents every month is important. There are always some great articles. Obviously, they should be filled with fantastic articles, but you're never going to read them all, but some of them may be particularly relevant to you. I would say after you scan through the table of contents, if you find anything that's of interest, collect them. If it's of interest to you, if it's controversial, or specifically relevant to your practice. Say you do a lot of deformity. If there's one specifically on comparing different approaches, anterior, lateral, posterior, for a given surgery for degenerative deformity, you know, you want to pull that article. And then you want to kind of go through it very methodically, and not just take the results and the conclusions. It's super important. I see so many articles published that I read the conclusions after I've gone through, and I say, okay, that's one I can't even believe. And then there's others that I say, okay, I have to take it with this much of a grain of salt, or have to take it at full face value. So it's really important. I say save in electronic format. I have been saving articles since I was a resident, which is many years ago now, and I have them all stored in a cloud drive. And so anytime I need to pull an article, whether it's from 1960 or from 2020, I have it. And it's very, it just, again, this is my own personal how I do it, but I would highly advocate. I think there was one point in time where I get a lot of paper journals. So I was ripping out the articles and stacking them on my desk until I could read them. Then once I read them, if I wanted to keep them, then I went to the electronic version and saved it. Everybody does things electronically nowadays, so I would skip the step of ripping out the paper copy. But somehow you do need to collect the ones, because you're not going to be able to read them right when you're deciding you want to read them. You kind of have to put them to the side and take your additional time. I think there's a lot of utility in keeping up on the literature and understanding the literature. It's super important when you're preparing for your boards. As I mentioned, talks and presentations, I must have, I don't even know how many hundreds of articles saved. So if somebody asks me to give a talk, although I will say I didn't have a talk on this, somebody asked me to give a talk on registries, national registries. I've amassed articles on that and the validity and the usefulness or utility of registries, or epidural abscesses, or any specific topic, and I have them all grouped by topic. I'm constantly reading the literature to update my practice. And as we know, spine care changes constantly, and we're doing more and more with registry efforts and really comparative effectiveness research. So we're understanding more about why certain procedures work better for certain patient populations or disease processes. So it helps when I'm talking to my patients, I can say, oh, you have a 30% risk of a reoperation within 3 to 5 years if you have a stable grade 1 spondylolisthesis and you get a decompression alone. And that's straight from Zohair Gogawala's study that was published in the New England Journal back a few years ago on that specific topic in a randomized controlled trial. You can also use it if you do later on in your career, if you ever do medical legal or quality reviews. Those all need to be supported by current guidelines and literature. So having kind of a stockpile and knowing the literature, understanding the literature really helps you when you're starting off doing any of these things. So in summary, I would say kind of set up your system. Set up your, I gave you kind of a stepwise fashion on how to analyze an individual article, but set up your system from the beginning of your practice of how you want to screen articles, how you're going to evaluate them, and then how you're going to incorporate them into your practice. I would say ebb and flow volume, that common is because you're busy when you get started in practice. You have a lot to think about, and you really are not going to have time necessarily to be reading all the literature that's out there. So you have to understand what your capacity is and how to incorporate that into your daily, weekly, monthly practice. This is important. Be cognizant of confirmation bias. So confirmation bias is when you only read literature that supports your own worldview, or you only pick articles that support your own worldview. I think that is, that can happen. It happens in other fields. It definitely happens in neurosurgery. So read all the literature. If you're going to look at risks and complications with lateral approaches to the spine, you don't want to just read the articles from those who say there's a very low risk, vessel risk, femoral, weakness in the quad, all of those things, nerve injury are really low. You want all across the board. You want experts, you want non-experts, you want systematic reviews, you want randomized controlled trials if they exist, you want large cohort studies, small cohort studies. So try to look at it all when you're trying to answer a question for yourself. And then incorporate them into your practice. The more you read and actually use the data that informs you, the more you'll remember it and be curious to go to that next step. Oh, when that next study comes out, what did they find? Oh, wow, they just said that laminoplasty was better than LAMI fusion or ACDF for cervical spondylitic myelopathy. I swear I just read something from 2 years ago that said the exact opposite. Let me take a look at that. How do I use that information to inform me to guide patient care? And then lastly, I think of future directions, and this isn't future directions for evaluating the literature, but future directions kind of on how you think about interpreting and evaluating the literature. I really do believe that it's our responsibility to ourselves, our trainees, and our patients to be lifelong learners. And this is just one small piece of that, right? And then I think the other thing is for you to individually think about, what is your contribution? Do you want to add to the literature? Do you want to simply interpret the literature? Or do you want to be part of a larger group that does kind of national studies looking at whether it's looking at novel techniques and being involved in registry efforts? Or do you want to get involved in guidelines efforts where you're critically reviewing the literature to bring consensus statements to our societies and our members? All of these things play a role as you develop your careers in the future. It's been a pleasure to talk to you folks today, and I would open it up for questions.